for those most harmful physical health results, we're also learning. And we are learning in the GBVRC, and we're trying to take opportunities from this. And that's what I'm trying to, I'll try to give some examples of in my presentation. We have the opportunity of having a medical, psychosocial, and legal team, and we learn new things every day. We try to deal with this in a dynamic fashion, and it can be important because in the first place we need to improve the quality of our services, medical, psychosocial, legal. You could call that operational research in a small way, and sometimes in a big way. We also try to establish best practices. Other people that want to start up the same kind of centers don't need to make the same mistakes. It's something that's often forgotten. And I think this kind of implementation research is coming more and more to the front in all the policy meetings you go to these days. And then remember, there's this long-term change. We think we can feed back to the community and accelerate this long-term change. Let me tell you how. And I'm going to give you 3 examples of findings where we try to do something about. First of all, I call it the taboo on child abuse. What do we know about sexual child abuse? Very little is reliably known. Often you read in the newspapers things like child sex tourism is on the rise, is rampant. You go to Mombasa and it's as bad as in Thailand, as reportedly in Thailand. You read in the paper there's an epidemic of boys, young boys being raped. So we have very few reliable figures, and our role as scientists is to provide those reliable figures. But we know that it's there, the sexual child abuse. It is, however, shrouded in silence, and by some in the past it has been written up and said that this is the thing you can do very little about. This belongs to the cultural, traditional attitudes. This is a taboo subject, you can't even talk about it, can't mention it, and there's nothing you can do about it. So, the way we set up the GBVRC in the beginning, in 2006, 2007, we expected to find mainly adolescent women, adolescent girls, adult women. To our surprise, as Dr. Soita has shown in his data, from the first 5 months in 2007, we were seeing less than 15-year-olds, more than half of the survivors. This went into, quickly we attained this 50%. In the beginning, one of our scientists was in fact talking to a reporter and mentioning the word epidemic. But as we have shown in our figures, it is constant. It was not a curve. So we were hitting on something we hadn't expected. We have the figures that Dr. Musimi has talked about. So the problem is not an epidemic, but the very important finding, and this cannot be underestimated, if you offer the service and you offer it in a public sector hospital, mothers, relatives, teachers will bring their children. So it was not a taboo, after all. That's my interpretation. It was, we didn't have anywhere to go. We knew about it, we had nowhere to go. So what do? You keep silent. And the fact that through offering the service in a public health sector, you can break this and access these children that are there in the community, I think that's a major challenge to be done, where we can directly do something. The second finding is a totally different order. It's the talk between lawyers. Again, we look at the Sexual Offences Act of 2006. And a child is anyone below 18 years of age. There are sentences of 15 years to life for sex with a minor, even if it is consensual, and even if it is between teenagers of the same age, or the same age group. So that's puzzling. We have to leave aside the fact that we have early marriages. It has been talked about as a form of SGBV. It is certainly a long-term thing to challenge. But we know that in some communities there are girls as young as 10, 11 married out. We also look at the KBHS 2008-2009. We see that the median is 18.2 for women, for girls, and 17.7 of debut of intercourse. By 15 years, we talk about 13 years of the girls, 18% of the boys. So we have a bit of a challenge between the law and reality. And at GBVRC, we are regularly confronted with cases, especially in the age group 15 to 17. And you could have different categories. You have the experimenting teenagers. They go further than what one of the partners would have liked. Okay, it is definitely not a good attitude, not a good experience for probably either of them. But we're talking 15 to life. Okay, there are usually miscommunication. The game of sex is a lot about communication, and miscommunication is there. Consent can be assumed, and it wasn't there, and then people end up at the GBVRC. And in Mombasa especially, we have the virginity issue. A girl below 18 has a boyfriend, family finds out she lost her virginity, and accuses the boy of rape. And if the family of the girl has more clout and possibly economic power than the family of the boy, that can lead to the boy actually ending up serving time. And we have those examples. So that you'll agree, I hope with me, that the criminal law here, 15 to life, we have this institution called Borstal, where minors end up in a prison. It is too harsh and not the best tool to solve these cases. When we get confronted with these cases, we try to explore all avenues. We advise the families and the survivors, trying not to press too much to involve the police. And we had the opportunity of, and the honor of having recently the commemoration of 5 years of our GBVRC. And there was Lady Justice Effie O'Rourke, who's known to the Kenyans in the audience as the chairperson of the committee on the task force on the follow-up of the Sexual Offences Act. And she promised, she told me that she knows that this is a problem, and she's looking into solving this particular matter in a different way. So that's where you can get from findings at your center, at your health service center, to the policy level, to changing the laws. That's quite an interesting finding. Finding 3 is confronting the community. This is the last one. As we said, local communities are tolerant, silent, permissible, sometimes condoning over some practices of SGBV. And we plan to do more study about, particularly about sexual violence. There seem to be some types of rape that are more accepted by community than others. This lady was looking for it, the way she was dressed, how she was walking around at night. It's important to look at what the community tolerates in order to be able to change. What we also see is that when people are confronted with a case of sexual violence, their attitude quickly changes. They say, even if she was dressed like this and walking around at night, she was not in no way responsible for getting raped. they change their own attitude and perception of SGBV. So confrontation with concrete cases may lead to change in permissivity and tolerance. And this is an aside, but we spend a lot of money when it comes to SGBV in big events. We assemble 1,000 people, we have a big march and show and everything, and there's a lot of important speakers and a lot of messages, but I wonder how much of that really gets through and gets to behavior change. And I wonder, I'm just posing it as a point, whether if you can directly go to community, you might change more. How can you organize this? And we're trying something out. We have a community outreach officer since recently, and when we are sitting together with the interdisciplinary team, we look for patterns of abuse. And we found a few, and we've done a few, well, not experiments, but a few reactions to concrete cases. For instance, in an area called Bombolulu, this is an area of northern Mombasa, there was a serial child rapist. We had 5 cases coming to the center, and knowing the underreporting, that's a lot, of girls from 3 to 9 years. We managed to get someone arrested, and the proof of the pudding is in the eating. After the person was in jail, there were no more this pattern of child rape in that area. In Changamwe, there was a rapist who offers jobs to young ladies at matatu stops. There were several cases. In Utange, another area, there was violent robbery with systematic gang rape. And as a last example, very recent, during the Mombasa riots of a few weeks ago, there were press reports of rampant rape in Kisauni. How do we do it? We have the community outreach officer, and we have our local networks. We have, as Liz mentioned, SGBV trained paralegals. That's people from the community, and sometimes often from vulnerable communities that are trained to a basic level of knowing their rights and being on the lookout for specifically infringement of human rights in SGBV. We also have community guides. We are piloting this with charity funding. We verify the facts. Very important. The Kisauni press reports we found were bogus. Someone said, oh yeah, there's been a lot of looting and there's been a lot of raping. And it was taken up in the press, but we verified. There was not more rape than normal in Kisauni in those days. And then you have a two-pronged approach. First of all, you go to the official way, the police, judiciary, local in that area. You liaise with the local police and officials. There's a chief, plays an important role. You assist, you promote correct investigation and prosecution. You also tell these policemen, this is not a laughing matter. This is not something where you have a survivor who presents in your police station and you say, oh, these women, they always commit their problems. There's change needed, yeah. And you also address the local community. That's why you liaise with the community leaders and organizations in the area, and you reach them with prevention messages, referral strengthening, change in tolerance level towards SGBV being the ultimate goal. If I may, Madam Chair, just 1 or 2 slides more. In terms of conclusion, and this goes a bit for the whole panel, we think that GBVRCs are more than a temporary fashion item. When we have this conference about integration, we have talked a lot about parachuted vertical programs. And sometimes even you have a vertical program that is only addressing a very small part of reproductive health issues, and you try to repair it by adding another vertical program, and you call that integration. That's too often in our area of reproductive health the case, donor-driven vertical programs. GBVRCs are addressing horrible things done to vulnerable people, and they can make real changes for the worse in their life. Offering the services is shown to unlock the taboo on child abuse. The center can hold a mirror to the society and confront them so that long-term change can happen. Improved application of the law will require investment in forensic equipment, supplies, and trained personnel. And as a last one, integration in public sector health facilities reaches the most needful and is sustainable. Further opportunities, and this is the really last slide, ownership to the public sector hospitals has to be given. I mean, an NGO can do startup, can work with the hospital, but in another 5 years, ICRH should be out. It should be fully a service that's fully owned and done by the hospital. Otherwise, we will have failed. We are planning, with charity funding again, rollout of GBVRC from provincial to district level, because there is the request by the district health management teams. We see these cases in our district hospital. We want to do something about it in a professional way. As I said, we train GBV paralegals. We train casualty staff from private hospitals in our region, because again, at their request. I think the GBV IMS, the information management system, and that's coordinated by UNFPA, is important because the more data we have, the more power to convince policymakers. Referral services have to be created. Understanding the justifications and motivations of the perpetrators and acceptance by the community of the same is an important point for further study. And feedback of policy and operational information to the lawmakers, to the judiciary, to the prosecution, to the police are important tasks and opportunities for GBVRCs. Finally, this is Mombasa. A couple of weeks ago, the commemoration of 5 years, we had a big march